Hey everybody, welcome to this NCLEX RN review session. Today we will navigate 6 next generation NCLEX test items, which are designed to refine your critical thinking and decision-making skills for real-world nursing scenarios. In this episode, I am challenging you to finish the entire test item and let us know how you did in the comments below. Let's begin. So here we go. This is about a 43-year-old male who arrived at the emergency department via ambulance reporting difficulty breathing, chest pain described as tightness, dizziness, palpitations, nausea, paresthesia in his hands, and a profound sense of impending doom. And we have the following diagnostic tests and lab results: ECG showing normal sinus rhythm, cardiac enzyme showing troponin at this time less than 0.01, D-dimer of 0.3 micrograms per ml, and the thyroid panel. We have a TSH level of 2.5 milliunits per liter, and free T4 1.2 nanograms per deciliter. So here your task is to identify the cues supporting the diagnosis of a panic attack as the primary condition, and to highlight the findings in the admission data and history and physical tables that are most critical for identifying a panic attack as the primary diagnosis. So here are the tables. So it's said here in the vital signs section, the blood pressure is 180/94, heart rate of 108 beats per minute, respirations 30 breaths per minute, temperature 98.6 degrees Fahrenheit. Patient is diaphoretic and trembling. Patient stated, "I can't breathe, I'm going to die." There's also chest pain, tightness, shortness of breath, palpitations, nausea, paresthesia in hands, and sense of impending doom. For the history and physical documentation, this patient has no known cardiac history, reports 3 similar but less severe episodes in the past 2 weeks, denies chest trauma or recent illness, reports ongoing divorce, loss of a child in a car accident last year, impending job loss and 20-pound weight loss, and insomnia for 2 months. In the general physical exam, patient is diaphoretic, trembling. Cardio, patient is tachycardic, no murmurs. For respiratory, he is tachypnic, has clear lungs. For neuro, he's alert, oriented, reports paresthesia in hands. Now you can pause here and finalize your answers. And when you're ready, you can go ahead and resume this video. Now let's take a look into one of the answers here. This one should be your highlight. "I can't breathe, I'm going to die." This is a statement that is very important for you to capture, because this includes both physical distress and emotional psychological fear, which align with DSM-5 criteria for a panic attack. Now remember that patients often describe panic attacks in very dramatic terms. And this sense of impending doom is actually a recognized hallmark of these episodes. And as a nurse in this situation, you need to treat what the patient says seriously, even if their vitals look stable, because subjective distress is part of the diagnostic picture. The next finding that you should highlight is this one: chest pain, tightness. Although chest pain always raises concern for cardiac issues, but in the context of panic attacks, it's usually due to muscle tension or hyperventilation, and the DSM-5 includes chest discomfort as a somatic symptom of anxiety. Now, in this case, the normal ECG and troponin help rule out myocardial infarction and confirms that the chest pain is part of the panic episode, not a cardiac emergency. The next finding that you should highlight is this one: shortness of breath. This is one of the most common physical symptoms of a panic attack, and can happen because of the sympathetic nervous system that is activated, which led to the patient's hyperventilation. And patients often feel like they cannot get enough air even if their oxygen saturation is fine. And when you recognize this as part of the DSM-5 criteria, this can help you focus on those other interventions like guided imagery or breathing or grounding techniques instead of automatically escalating for respiratory failure. Another finding that you should highlight is this one: palpitations. This is referring to that sensation of the heart pounding. It's racing. And even though we may not see dramatic changes on the monitor like arrhythmias, the patient's perception of this symptom still matters, which is another DSM-5 feature of panic disorder. And here, you need to differentiate between subjective palpitations and actual cardiac pathology like tachyarrhythmias, which requires a good assessment and calm reassurance. Another is this one: nausea, because gastrointestinal symptoms like this one are often overlooked in panic disorders, but they're part of the DSM-5 criteria. And remember that the gut is richly connected to the brain via the gut-brain axis, and during panic episodes, the autonomic changes can cause nausea. There's going to be abdominal cramping or even vomiting. And when you recognize these as anxiety symptoms, this can prevent unnecessary gastrointestinal workups, and you should be able to focus care on the real cause. Another finding that you should highlight is this one: paresthesia in hands, referring to numbness. There's tingling sensation in the extremities, and this is caused by hyperventilation, which leads to low carbon dioxide or hypocapnia in the blood. And this can significantly alter the pH. It can cause nerve excitability, which can result to pins and needle sensation. And this specific symptom points strongly toward panic and not other causes like stroke or neuropathy. And we also have this one: sense of impending doom, which we will highlight in a minute here. And so there are two areas wherein there is documentation about paresthesias. Now let's look into the sense of impending doom. This is one of the most classic features of a panic attack, wherein patient can feel like they're going to die or something terrible is about to happen. And this one is very distressing, and this can lead to unnecessary medical testing if not recognized correctly. But you, as the nurse in this situation, you should know that this is a psychological hallmark, not a predictor of actual physical harm. Now let's look into the other section of the documentation here. We have diaphoretic. This is sweating, and this is caused by sympathetic response, just like the increased heart rate and dilation of the pupils. This one is observable, also measurable physical sign that supports the subjective feelings of anxiety. And so when you see a patient who's very sweaty, if they're panicked and saying, "I can't breathe," then that's going to add weight to the panic attack diagnosis. We have more. There's another diaphoretic right there at the bottom. And respirations of 30 breaths per minute, we call that tachypnea, is a objective manifestation, and also vital signs that you should not ignore. That tells us the patient is breathing very rapidly, and when you are going to pair it with the shortness of breath and the paresthesias, it supports hyperventilation, which is physiologically consistent with a panic attack. And having a measurable sign like that one can help you to document the clinical evidence beyond just the patient's report. Now, what else do we need to highlight here? This one right here, it said reports 3 similar but less severe episodes in the past 2 weeks. Even though this is part of a historical data, this tells us the patient may be developing a pattern of recurrent attacks, and this can shift the diagnosis from an isolated panic attack to possibly panic disorder. And recognizing the recurrence is very critical for long-term management and referral for psychiatric support or even cognitive behavioral therapy. Now, we have the documentation about tachypnic, which is basically reflecting the respirations of 30 breaths per minute. And saying someone is tachypnic aligns with their respiratory rate finding as well. Now, the rest of these manifestations are not going to be highlighted. If you mistakenly highlighted the blood pressure of 180/94, we know that is already elevated, right? But this one is non-specific. It's part of the fight or flight response from the sympathetic nervous system. Even though it reflects the body's reaction to the panic, it's not part of the DSM-5 diagnostic criteria for panic attacks. So you would see high blood pressure and many other conditions like MI, stroke, anxiety, even pain. Now, looking into the heart rate of 108 beats per minute, again, this is tachycardia, and it's physiologically consistent with panic, but it's not as helpful diagnostically as palpitations, which are part of the DSM-5. And many patients may have a higher heart rate for other reasons. It could be from fever, could be infection or dehydration. Even though it's part of the clinical picture, it's not a primary cue for the diagnosis. If you attempted to highlight trembling, this is certainly associated with anxiety, but compared to more specific DSM-5 symptoms like paresthesia or palpitations, it is a less critical diagnostic cue. Even though it's real and noticeable, this one doesn't really help us much with distinguishing panic attacks from other types of anxiety. Now, if you selected or highlighted reports ongoing divorce, a loss of a child in a car accident last year, or impending job loss, or 25 or 20-pound weight loss, or maybe insomnia, these are important psychological stressors that explain why someone might be experiencing panic attack or anxiety, but they are not symptoms of a panic attack. So these are just background factors that can help you understand the context, but not make that diagnosis. And if you selected denies chest trauma or recent illness, well, this is a negative finding that helps rule out other causes like PE or pneumonia. Even though it's good to document this one, that is not going to help confirm the panic attack. It's only going to help eliminate the alternative diagnosis, so it's not a highlight for confirming a DSM-5 criteria. So, looking into this test item, this one focuses on cue recognition, which especially is going to ask you to identify the cues that meet the DSM-5 diagnostic criteria for a panic attack. Now, when you're analyzing a case, you have to prioritize those subjective symptoms that match the diagnostic checklist. So think about palpitations, chest discomfort, and sense of impending doom. Next to that, you're going to validate the subjective cues with the objective findings, like the rapid respirations, also the observed behavior, tachypnea, and a recurrence of the patterns. And also use negative or non-specific findings like high blood pressure or psychological stressors to rule out other diagnoses, but do not confuse them with the diagnostic criteria. What you need to do here is to focus on the patterns, recurrent panic attacks, or similar episodes in recent weeks that suggest a possible disorder, not just a single episode. So here you can pause and reflect on your answers and the rationales that I just gave you. All right, when you're ready, let's move on to our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says here, the nurse reviews the healthcare provider orders, noting the prescription for alprazolam 0.5 milligrams TID PO for 1 week. The nurse prepares to educate the patient on potential adverse effects to ensure safe medication use during this period. So you have the nurse's practice notes regarding the patient's arrival at the ED via ambulance, and we have the entry of orders by the healthcare provider. At 10 in the morning, lorazepam 1 milligram IV push stat was given, or it was ordered. At 11 in the morning, alprazolam 0.5 milligram TID PO for 7 days. So your task here is to complete the bow tie diagram options by dragging them to specify the most critical adverse effect of alprazolam during use, 2 teaching points to mitigate this risk, and 2 patient statements indicating understanding of the teaching. You know what to do. Here's the table of options. So we have the adverse effect options: respiratory depression, paradoxical agitation, confusion, amnesia, and sedation. Now, what do you think would be the best fit here? The correct answer is sedation. Why? Well, remember that alprazolam is a short-acting benzodiazepine, and its main job is to calm the nervous system by boosting a brain chemical called GABA. Remember that? That is a gamma-aminobutyric acid. Even though it can help with anxiety, one of the most common side effects is sedation. Not just common side effect, but it is also considered as adverse effect. It means it can make people feel really sleepy or drowsy. And get this, up to 40% of people taking alprazolam feel sedated. And that's quite a huge number for someone who works full-time, one who drives or has a busy daily life, like this patient who is a 43-year-old client. This can be a real safety concern because drowsiness and sedation can lead to car accidents. It can lead to workplace mistakes, even falls at home. And so when you're thinking, what should the nurse teach first? You got to go with what's most common and what's most likely to cause harm. And in this case, sedation checks both boxes. Now, if you selected amnesia, why is this not a good pick? Well, even though alprazolam can cause amnesia, specifically anterograde amnesia, where the person can have trouble remembering things that happen after they take the drug. Kind of sounds scary, but here's the deal. This adverse effect doesn't happen very often, and there's only about 10 to 15% of people, and usually at higher doses than what most people get for outpatient use. Now, even when it happens, it's not usually dangerous. It just means someone might forget a conversation or a movie, not that they're going to fall asleep at the wheel. So my NCLEX tip for you when you're comparing the adverse effect, you got to pick the one that happens the most and puts the patient in immediate danger. And that's why sedation is the best choice. Now, looking into confusion, why is this somewhat kind of important? Well, this is something that can definitely raise some red flags, especially when you're talking about drugs that affect the brain. And it can lead to poor judgment, can lead to committing mistakes or safety issues. But this one is a rare adverse effect of alprazolam, only seen in about 2 to 3% of patients. And even then, it's mostly in older adults, especially those with memory issues or multiple medications. And go back into the scenario, our patient is 43 years old. He is healthy and not taking other medications. So the chances are very low here. Also, the confusion is not a predictable response in this age group. So yes, we will be observing this patient for that adverse effect, or for those who are quite older with more risk. But for this client, sedation is much more likely to happen and will require more urgent teaching. So the tip for you here is to focus on what's very common, predictable, and dangerous, especially for this specific type of patient. Now let's talk about paradoxical agitation. This kind of sounds scary. And imagine taking a calming medication and ending up being restless or even aggressive instead. This is what we call as paradoxical agitation, and it can happen with benzodiazepines, but it doesn't happen very often. Now, why is this not a teaching priority or a adverse effect? Well, this one is extremely rare, about less than 1%, and mostly happens in older adults or people with mental health issues or those taking high doses. Now, for a healthy middle-aged adult taking a low dose, remember that the order here says about 0.5 milligram 3 times a day. It's not something that you'd expect or prepare for right away. And the bottom line here is that it's something that we should know about, but it's not something that you lead with patient education. So remember about the dose here. It's not quite big. Now, looking into the next option, respiratory depression, why this sounds quite serious. Now, anytime a drug affects breathing, that's definitely going to take your attention, especially with central nervous system depressants like benzodiazepine. But here's why it's not going to apply here. Even though alprazolam can slow down a person's breathing, that's usually going to happen in patients taking high doses, especially when they're taking the intravenous form or when it's combined with opioids. And remember, our patient is taking low dose by mouth, and he's not taking any other sedating drugs. He is quite young, otherwise healthy. So in this case, it's just not a realistic risk. And yes, severity matters, but if something is very unlikely, it doesn't outrank a more common dangerous side effect or adverse effect like the sedation that we have already identified. Now let's move on into the 2 teaching points here. And the options are: check mood changes daily, avoid combining with other sedatives, report unusual agitation immediately, monitor for memory lapses, take at bedtime if drowsy, avoid driving until effects are known. Now, I want you to pick the best answers here. And one of those is this: avoid driving until effects are known. So we know that sedation can slow down a person's reflexes and it's going to make a person drowsy, sedate. And driving under the influence, even a prescription medication, can be very dangerous. Another, take at bedtime if drowsy. This is very practical. This simple timing change can help the patient function better during the day. And that is why we're going to pick that one. Now, let's look into the other options. If you selected monitor for memory lapses, this kind of sounds smart. Monitoring memory might seem like a proactive idea, but memory loss is not the most common adverse effect, and it's usually not dangerous. And this teaching doesn't help prevent the biggest risk, which is sedation and the accidents that we have already talked about. And the better use of time, you got to teach patients what to do about the drowsiness. Another here is report unusual agitation immediately. This kind of seems responsible. Of course, we want patients to speak up if they feel weird or if they're feeling kind of panicky, but it has that lower priority. Again, this one relates to paradoxical agitation, which is very rare in people like this client. And it's not wrong to report unusual symptoms, but we don't just start our teaching here. It's just not likely. So you need to focus first on what's likely to happen and can hurt the patient today. All right, let's move into the next option. Avoid combining with cold medications that make you sleepy or other sedatives. Avoid combining with other sedatives. This is a good precaution. We know that cold medications that contain, such as diphenhydramine, can lead to sedation. And here's the thing. This is a backup teaching point. It's helpful if the patient is using other sedatives, but it's not as critical as don't drive or take it at bedtime. So this is something that you can use after the most urgent safety points are already covered. All right, pay attention. Now, the next thing that you're going to pay attention here is check mood changes daily. Another incorrect option. This kind of sounds useful. We know that monitoring of the mood can be helpful with psych medications, but this one is quite vague because our patient has no history of mood disorder, and this doesn't relate to the sedation, the main concern. So even though it's not harmful, it's also not focused. And remember that good teaching is specific, should be safety focused, and should be relevant. But this one doesn't really, it doesn't hit the mark as well. Now, let's look into the client statements indicating understanding. We have the following options. I'll avoid cold medicines that make me drowsy. I'll watch my mood to avoid getting confused. I'll call my doctor if I feel unusually restless. I'll keep a notebook to track any memory issues. I'll take it at night if it makes me sleepy. I won't drive until I know how this affects my alertness. So one of the answers is this. I won't drive until I know how this affects my alertness. This one shows that the patient clearly understood that sedation is the most common and safety threatening adverse effect of alprazolam, and this can lead to slow reaction time and can also impair their judgment. So they're applying that knowledge in a very proactive way by avoiding to drive, which aligns perfectly with the nurse's safety teaching. So this one is also a direct high impact action that's going to help prevent injury, harm, and this is exactly what NCLEX prioritizes. The other statement should be, I'll take it at night if it makes me sleepy. So instead of fighting the drowsiness, the patient is actually adjusting their routine to take the medication when sedation won't interfere with their work, the driving, or daily responsibilities. And that's not only practical, it's also proactive. So this one also shows the patient is internalizing the teaching and applying it to their real life, which is ideal for outpatient safety education. So the rest of the options are incorrect. So if you mistakenly selected, I'll keep a notebook to track any memory issues? Well, this is more of focusing on anterograde amnesia, which is even an adverse effect, but this is far less common, only about 10 to 15% occurrence. And again, this is less than sedation and not really the top concern for this otherwise healthy 43-year-old. So the bottom line, the patient statement is not wrong, but this one focuses on nice to know risk rather than must know. So eliminate this one. Now, if you selected, I'll call my doctor if I feel unusually restless, this also misses the priority because this refers to the paradoxical agitation, which is a rare and unpredictable reaction wherein the drug causes anxiety or hyperactivity instead of calming. So this one kind of sounds responsible, but it shows the patient did not absorb the main safety teaching about sedation and activity modification. So this one is also a good thing to report about the adverse effect, but this isn't the one to lead with during the routine teaching for a low-dose outpatient prescription. If you selected, I'll avoid cold medicines that make me drowsy, well, this one is a valid precaution. Cold medications with sedating antihistamines could increase central nervous depression when combined with the alprazolam, but this one doesn't address the bigger picture, which is how the patient manages sedation itself. And this is more of a follow-up safety tip. It's not really a substitute for core instructions like avoiding driving or adjusting dose timing. Now, if you selected, I'll watch my mood to avoid getting confused, this kind of mixes up with the unrelated and rare adverse effect. We're talking about confusion and the mood changes, which are not expected in this patient. And this one states, or it suggests the patient did not grasp the key point, which is sedation, which is the primary risk, not cognitive or emotional shifts. So, in this test item, you make sure to teach the patient to recognize and also to respond to the most likely danger, and make sure that you evaluate their understanding based on how well they apply that information. You can pause here and reflect on your answers, and you can resume in a minute. Let's move on to...
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
The next test item. It says, the nurse reviews the nurse's progress notes, laboratory, and diagnostic test results. His symptoms resolve following administration of lorazepam 1 mg IV push. The emergency department physician diagnoses a panic attack. So, looking into the nurse's progress notes here, around 10 a.m., let's jump into 10:30 documentation, where it says, symptoms resolving post lorazepam, vital signs blood pressure 140/88, heart rate 80, respiration 16, patient calmer, reports feeling less overwhelmed. At 12 noon, patient reports persistent palpitations, occasional chest tightness, feeling on edge, difficulty concentrating, episodic dizziness, insomnia. It denies shortness of breath, vital signs, blood pressure 142/90, heart rate 88, respirations 18, preparing for discharge. Now, we have additional information regarding the healthcare provider orders. So at 10 o'clock, the medical provider ordered the lorazepam 1 milligram IV push stat. Orders for the cardiac enzymes, troponin, CKMB, D-dimer, thyroid panel, 12-lead ECG. At 11 in the morning, alprazolam 0.5 milligrams 3 times a day, PO for 7 days was ordered. And also referral to primary care physician for follow-up evaluation and treatment. Now let's look into the lab results. I think we already have seen this. We got the ECG, cardiac enzyme results, the D-dimer, and the thyroid panel for the TSH and the free T4. So feel free to pause this video and review those results. Now, your task this time is to click to indicate the problems that the client is experiencing based on the associated clinical manifestation. Each row can have multiple responses. So here's the matrix. We have the clinical manifestations, persistent palpitations, occasional chest tightness, feeling on edge constantly, difficulty concentrating, episodic dizziness, insomnia. And we have the conditions here: panic disorder, generalized anxiety disorder, cardiac arrhythmia, and hyperthyroidism. All right. When you're ready, let's answer this test item. All right. What do you think about the persistent palpitations? Do you think that this can be associated with all 4 of them? Well, let's pay attention first to panic disorder. Yes. So here, you got to think of a full-blown panic attack. The heart rhythm races. The body thinks that it's in danger, and so you get that fight or flight response. And remember that palpitations are a key DSM-5 symptoms here because of sympathetic nervous system overactivation. And so the fact that the patient has had multiple episodes and improves with lorazepam, then it supports that it's likely due to panic, not a heart problem. Persistent palpitations is also associated with generalized anxiety disorder because GAD can cause constant low-level stress that can keep the sympathetic nervous system in overdrive. It can lead to persistent palpitations, and it's not as dramatic as a panic attack, but that always on edge feeling can make the heart beat faster over time. And palpitations is also associated with cardiac arrhythmia. So this is a classic cause of palpitations like atrial fibrillation or SVT. And even though the ECG was normal, arrhythmias can come and go, so you cannot rule it out yet based on a single reading. So you gotta keep it on your radar. Another is hyperthyroidism, because when there is too much thyroid hormone, everything can speed up, including the heart rhythm or heart rate. But here in our patient's case, the thyroid panel is normal. The TSH is 2.5. Free T4 was 1.2. So it's less likely. But still, early hyperthyroidism can sneak by lab, so don't dismiss this entirely. So that's still part of the association. Now let's move into the next category, occasional chest tightness. What do you think about this one? Well, this is associated with panic disorder because that feeling of chest tightness or pressure often comes from muscle tension or hyperventilation during the panic attack. And it's also part of the DSM-5 list. And if this happens with anxiety and goes away with calm, it's likely panic driven. Also, occasional chest tightness is associated with cardiac arrhythmia because if an arrhythmia decreases blood flow, the patient might feel chest pressure or tightness similar to angina But again, the normal ECG and troponin reduce, but don't eliminate this concern. So the other options or other conditions are incorrect here. Chest tightness, occasional chest tightness is not really associated with a GAD, because GAD is more about mental tension than physical sensations. And symptoms like chest tightness are not central to general anxiety disorder. So this would show a misunderstanding of the GAD's clinical picture. And hyperthyroidism is also not associated with occasional chest tightness, because even though it can cause palpitations and heat intolerance, chest tightness isn't usually how it shows up. Now, if you're going to pick this, you might be focusing too much on the hard effects of the thyroid hormone, not the broader symptom profile. So you got to be careful in choosing your condition here. Now let's look into the next category, feeling on edge constantly. Well, this one is associated to panic disorder. After a few panic attacks, people often live in fear of the next one. And that is what we call as anticipatory anxiety, which is a hallmark feature. So if the patient says they feel on edge all the time, that is a very strong clue. And feeling on edge constantly is also associated with generalized anxiety disorder. This phrase is textbook GAD. That restless, wound up feeling is part of the DSM-5 criteria. And you combine this with a chronic worry, then that's going to fit very well. However, feeling on edge constantly is not associated with cardiac arrhythmia, because arrhythmias cause physical issues like heart racing, dizziness, but not psychological tension. And picking this one shows confusion between psychological versus physiological symptoms. Feeling on edge constantly is also not associated with hyperthyroidism, even though hyperthyroidism can cause nervousness, but it's usually episodic, which is tied to high hormone levels. Whereas feeling on edge constantly points more of a psychological route than a hormonal one, especially with normal thyroid laboratory results. Now let's look into the next category, difficulty concentrating. This one is associated with panic disorder. And so when a person is constantly on alert for the next panic attack, then it's very hard for them to focus. Their brain is always scanning for any threat, so it's going to make it hard for them to concentrate. Difficulty concentrating is also associated with a GAD, and this is one of the core symptoms of GAD. And here, their mind is racing. There is somewhat kind of full of what ifs, so it's no surprise that the attention really is going to suffer here. Now, the difficulty in concentrating is also associated with hyperthyroidism, because an overactive metabolism can make people jittery. It's going to make them so scattered. So it's like too much caffeine. So yes, it can impair focus even if labs are normal. All right, so let's put that check right there. However, difficulty concentrating is not really associated with cardiac arrhythmia. Even though the arrhythmia can do an impact on the blood flow, it can lead to dizziness, fainting, but not mental fog unless there is severe cerebral hypoperfusion, which is not the case here. All right, let's move on into the next category, episodic dizziness. This one is associated with panic disorder because during a panic attack, people can breathe really fast. They are hyperventilating, which can lower their carbon dioxide level, and this can lead to lightheadedness, dizziness. So this is a classic DSM-5 symptom of panic. Also, episodic dizziness is associated with arrhythmia, because when the heart rhythm is off, it might not pump enough blood to the brain. It can lead to dizzy spells, and it's still on the table until we've ruled it out. And also associated with hyperthyroidism, even though it's rare, but this is possible. because a fast heart rate from excess thyroid hormone can cause dizziness, especially in elderly patients or those with other health comorbidities. And this one is not associated with generalized anxiety disorder, because with a GAD, it doesn't usually cause episodic dizziness. It's more of a constant cognitive load, not sudden physical symptoms. And so if you're going to pick this one, it shows that you are confused with a panic disorder. Now, let's look into the insomnia here. We're almost finished. So insomnia is often associated with panic disorder. So when someone fears the next attack, the person can end up worrying, and there's going to be hyperarousal that's going to make them hard to fall asleep. And many panic attack patients complain of poor sleep patterns as well. And the same is true with GAD, because insomnia is part of the DSM-5 symptom. Worrying late at night, racing thoughts, and restlessness all contribute. And if the patient has stress and chronic worry, then generalized anxiety disorder is high on the list. And also associate with hyperthyroidism, because this is going to crank their whole system. So you got to think about stuck in the fast forward kind of mode. And with hyperthyroidism, it's going to make people feel too wired to sleep, even though the labs are normal, but early thyroid dysfunction still can't be completely ruled out. And so insomnia is not really associated with cardiac arrhythmia unless the patient has palpitations or at night that's going to make them wake up in the middle of the night, which is not the case here. And arrhythmias don't typically disturb sleep. And this option shows, if you're going to select this as part of the conditions, then you're probably showing a lack of connection between the symptom and the root cause here. So for this test item, this is basically gauging your ability to distinguish the physical from the psychological symptoms. And you need to recognize the patterns of the diagnostic criteria. And you have to know which symptoms are key versus peripheral. And don't forget to understand when the lab results rule something out and when they don't. So you got to pay attention. All right, let's move on into our next test item, number 4.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
It says, the nurse reviews the healthcare provider orders table, noting the alprazolam prescription and referral to primary care. The nurse anticipates a medication adjustment for long-term management. So I want you to scan into the healthcare provider orders shown in the table. So your task is to choose the most likely options for the information missing from the statements by selecting from the list of options provided. So here's the statement. It says, the nurse anticipates the healthcare provider will discontinue blank and initiate blank due to blank. And here are the options. For the first blank, the options are propranolol, sertraline, alprazolam, lorazepam. For the second blank, the options are atenolol, buspirone, clonazepam, sertraline. And for the third blank, the options are FDA approved for panic disorder, contraindicated in asthma, slow onset of action, and risk of dependency. All right, when you're ready, let's supplement all these blanks. All right, what do you think would best fit the first blank? It says the nurse anticipates the healthcare provider will discontinue. The answer here is alprazolam, because this is a short-acting benzodiazepine that works fast by enhancing the calming neurotransmitter GABA, which temporarily calms anxiety. Kind of sound helpful, right? But the issue is that this medication is habit forming. So people will tend to develop tolerance very quickly, and even a few days of use can lead to withdrawal symptoms like rebound anxiety or even seizures when the patient discontinues taking the drug abruptly, right? And because of these risks, the best practice is to limit benzodiazepines such as this one to short-term use only. So, as a nurse here, your role is to recognize when a medication is no longer appropriate, and you need to anticipate that the provider will want to taper and discontinue it in favor of a safer long-term medication like the one that we'll be talking about. So, when you selected alprazolam here, this is actually prioritizing patient safety and also preventing addiction. So this should be your top priority. Now let's move into the next part of the statement. It says, and initiate blank. So our options are atenolol, buspirone, clonazepam, sertraline. The answer is sertraline. Okay. Now, why do you think that sertraline is the answer here? Remember that sertraline is a antidepressant medication. It usually comes in the brand of Zoloft, and this is one of the most evidence-based FDA approved SSRI for panic disorder. And this medication works by increasing the serotonin levels in the brain, which will help reduce the frequency and severity of panic attacks. This one is not addictive. This medication is safe for long-term use, also recommended by clinical guidelines. And when this medication is started while tapering off the alprazolam, this is going to help the client transition safely from a very risky medication to a much more stable medication and a sustainable treatment. So this is exactly the kind of clinical thinking that NCLEX expects you to have. So you're actually looking for short-term versus long-term goals and protecting your client's future well-being. Now let's move into the other options here. Why not clonazepam? Well, remember that clonazepam is a long-acting benzodiazepine. Sure, it can help with the panic disorder, but it still carries the same addiction and withdrawal risk as the alprazolam. So it's like trading one risky drug for another. So that's not the direction we want to go in a long-term anxiety management. So buspirone is also incorrect because this is only great for generalized anxiety disorder, but not for panic disorder. And buspirone is not FDA approved for panic attacks and does not work as effective for sudden onset symptoms. So you'd be giving a medication with limited benefit for this particular diagnosis. Now, if you selected atenolol, this is not appropriate. This is a beta blocker like the propranolol. It can calm the physical symptoms of anxiety, but it does not treat the emotional or cognitive components of panic disorder. And it's not FDA approved for panic disorder as well. So if you're choosing this one, well, you're probably not really understanding the comprehensive psychiatric treatment of panic disorder. So Pay attention. Now let's look into the reason why alprazolam should be discontinued. We got the options: FDA approved for panic disorder, contraindicated asthma, slow onset of action, and risk of dependency. I think I've already talked about this. That's the answer: risk of dependency. This is the main reason why we need to discontinue administering or discontinue giving this medication as ordered by the healthcare provider, because of its high potential for dependency. Even with short-term use, this medication can cause rebound anxiety, even withdrawal seizures. So we want this patient to switch to a much safer medication like sertraline. All right. Now, why are the other options incorrect, such as slow onset of action? We know that sertraline can take 2 to 4 weeks to work fully, but that's just a characteristic, not the reason that alprazolam needs to be stopped. Now, if you selected contraindicated in asthma, well, this is applicable if you selected atenolol, which can worsen asthma. And it has nothing to do with alprazolam or sertraline, which do not affect lung function. If you selected FDA approved for panic disorder, well, this is good for initiation, but not for discontinuation. We know that sertraline is FDA approved for panic disorder, and that's a reason to start it. But this doesn't explain why we are stopping alprazolam. So you need to match the reason to the specific action. All right, we're almost through with our unfolding case study. Let's jump into the next question, number 5.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions. Practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says the nurse is preparing the patient for discharge and reviews the chart, identifying client needs, managing acute panic symptoms, addressing chronic stress, and preventing recurrence of panic attacks. All right, let's scan through the nurse's progress notes here. It looks like we have already reviewed these documentation, but if you want to scan it one more time, go ahead. Feel free to do that. Now, your task in this item is to click to specify the potential nursing intervention that would be appropriate for the care of the client. Each client need may support more than one potential nursing intervention. Each category must have at least one response option selected. So here's the matrix. So pay attention to the categories here: managing acute panic symptoms, addressing chronic stress, and preventing recurrence. When you're ready, let's resume answering this test item. Now, for the category, the first one, managing acute panic symptoms, what do you think would be the best interventions here? Well, one of those is to teach progressive muscle relaxation. This is a hands-on, also evidence-based technique that's going to help patient regain control over their body during a panic attack. And so when they are going to tense and then relax different muscle groups, it's going to directly reduce their physical symptoms like chest tightness and trembling, which are classic manifestations of sympathetic overactivation. And when you're going to teach the patient this skill, this is going to empower them to manage their symptoms when they arise, which is exactly what NCLEX prioritizes. All right, so this is patient-centered care and teaching coping strategies. Do not neglect this one. The next answer here would be teach diaphragmatic breathing. So when a patient will have hyperventilation, their respirations goes up at 30 cycles per minute. Their carbon dioxide level in their blood can drop significantly, which will lead to dizziness, tingling sensation, even worsening in their panic attack. Now, when they do the diaphragmatic breathing, this is going to reverse that. This is going to calm their nervous system. This will also restore the balance in the CO2 in their blood. This is very practical, immediately useful nursing intervention. And this is exactly the type of skill-based teaching that you need to share to your patient. Now, another answer here is this one. Encourage use of a panic attack journal. Because when they use this, and when they're recording the triggers, the patterns, and how they are going to respond to the panic symptoms, in this case, they're going to be able to identify the situations like work meetings as triggers, and this is going to allow them for targeted interventions, and it's going to help enhance self-awareness. It's going to give the patient more control, which is part of the recovery, and also one of the main aspects in your role as a mental health care provider here. Now, the last option, monitor respiratory care, even though this is important during the initial assessment, but the patient's respiratory rate has already stabilized, now 16, so we're not checking the box here. This is a passive action. Now, let's look into the next category. Addressing chronic stress. Now, one of the answers here is this one. Teach guided imagery. This is a very powerful, specific, and evidence-backed tool for managing ongoing stress. This is going to help the patient mentally escape stressful situations by helping them to focus on calming mental pictures. And for someone experiencing major life stresses like divorce and grief, this technique promotes psychological relief and long-term coping, and also part of your role in very ideal for discharge planning as well. Another intervention that you should select here is coordinate referral to social work. This is very vital in identifying when patients need support beyond what healthcare alone can provide. So when you're referring to a social worker, this is very critical because the patient is facing financial hardship, there's grief, social isolation, and remember that NCLEX expects you to think holistically, not just about the symptoms, but about the whole person. Another answer that you should select here is encourage participation in a support group. And so when you're allowing them to connect with others who share similar experiences, that can significantly reduce isolation, and it will help build their resilience. And for someone who has lost a child and is going through a major life change, the peer support can be transformative for this patient. And if you're encouraging the use of community resources, that's also a fundamental part of your role as an RN. And NCLEX is going to expect you to do the same. And if you selected teach stress reduction techniques, it's not something that we're going to check off here because this one is too vague. The one that we have identified already, guided imagery, using journal, mindfulness, are all more specific and more actionable. So in the NCLEX, it usually is going to favor those interventions that are clearly defined, that are evidence-based. So when you are picking a generic option like this one, it lacks precision, and so this is not going to be our one of the answers. You're going to eliminate this one. Now let's look into the next category, preventing recurrence. And one of the answers that you should highlight or check is teach mindfulness mediation. This is going to teach the patient to stay in the present and observe their thoughts without judgment. And this one is really going to help them reduce anticipatory anxiety, and it's going to prevent panic attacks. Another option is to reinforce follow-up with primary care, because patients with recurrent panic attacks need much more of structured follow-up to adjust medications, and also to evaluate therapy needs and monitor their progress. Another is encourage regular exercise, because this one can promote release of endorphins and will reduce stress hormones like cortisol. And this has been shown to significantly reduce anxiety symptoms. This one is very practical and also appropriate in your role in strategizing for long-term management of panic attack. And if you selected teach cognitive restructuring, this is actually a core element of cognitive behavioral therapy and will require formal training in psychotherapy, which is beyond our nurse's scope, RN scope of practice. Even though this one is helpful, it is not something a nurse can do independently and implement. So this is going to be an incorrect option for you. So we're going to leave that box unchecked. All right. So don't forget that this test item is testing you to distinguish between the acute symptoms relief and long-term stress management. So you have to select those evidence-based, RN-appropriate interventions and something that can promote holistic patient-centered care using those practical tools that you can teach, and also to help coordinate with the care. So you'll often see this type of questions and where all options seem helpful, but your task is to pick the most appropriate intervention based on the timing and also the scope of the practice and also the specificity. All right, let's move on into our next test item, number 6. This is the 4th attempt. All right, let's move into our next test item, number 6.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
It says here, after discharge, the patient follows up with his primary care physician as ordered. The PCP initiates a comprehensive treatment plan, including sertraline 50 milligrams daily, cognitive behavioral therapy, and mindfulness meditation. The nurse reviews a follow-up flow sheet over 4 visits after the client begins sertraline 50 milligrams daily, cognitive behavioral therapy, and mindfulness meditation. So let's look into the documentation here. It said that on day 1, after the emergency department discharge, the patient's blood pressure was 140/88, heart rate of 80, 16 respirations, anxiety level 8, and panic attacks 1. On the second week, blood pressure is 138/86, heart rate of 78, respiration 16, anxiety level of 6, and panic attack 1. On week 4, blood pressure is 130/82, heart rate of 76, respirations of 14, anxiety level 4, no panic attacks. On week 8, patient's blood pressure is 128/80, heart rate 74, respirations 14, anxiety level of 3, and panic attack 0. So your task right now is to select the 2 statements that best describe or indicate the effectiveness of the treatment plan for managing the client's panic disorder. And here are the patient statements. One is, I sometimes feel a bit unsteady, which reminds me of my old symptoms. I'm sleeping better most nights, but I still wake up occasionally feeling anxious. I've been able to handle work meetings without feeling overwhelmed. The mindfulness breathing techniques help me stay calm when I feel stress building up. I feel more optimistic about my future since starting therapy and medication. I haven't experienced a panic attack in over a month, and my overall anxiety has decreased significantly. So you can pause here and scan one more time those patient statements. Now, when you're ready, let's go right ahead. Let's answer this test item. And so one of the correct options here would be this. The mindfulness breathing techniques help me stay calm when I feel stress building up. This is very important because this shows the patient is actively using a learned skill, such as the diaphragmatic breathing, to prevent escalation of stress, which is self-management in action. And remember that in panic disorders, this is not just about treating the symptoms after they happen, it's about preventing them. And this one shows the patient is using non-pharmacological strategies to interrupt the panic cycle. And this also points to improved self-efficacy, which is a cornerstone of anxiety disorder recovery. And the other option that you should highlight or check would be this one. I haven't experienced a panic attack in over a month, and my overall anxiety has decreased significantly. This is your gold standard outcome because this one is direct, it's specific, and also measurable. Everything you'd want when evaluating the effectiveness of a treatment plan for a panic disorder. So that's a strong indicator, especially that they never had any panic attacks over a month. And also there is also reduction of anxiety. So this really matches the flow sheet information, which shows anxiety scores dropping from an 8 down to a 3 by the 8th week. So pay attention to the documentation and the flow sheet. That's quite significant of an improvement here. And this one reflects that there is integration of the subjective and objective data, which is a skill that NCLEX love to test. And so here you're actually linking what the patient says with what the data shows. So this one confirms effective management of the core symptoms. Now let's look into the other options here. If you selected, I feel more optimistic about my future since starting therapy and medication. Well, this is not really the best choice, even though this is great news, but this statement is still too vague because optimism is a general mood indicator, but is not specific to panic disorder symptom relief. And there is no mention of panic attacks, anxiety levels, or even how they're functioning under stress. So think about this item as a secondary emotional benefit, but not a primary outcome. So with this, we're going to have to look into the next one here. If you selected, I sometimes feel a bit unsteady, which reminds me of my old symptoms. This is incorrect. This is a red flag. It's not a sign of improvement. And feeling unsteady might be a side effect of the sertraline, especially during the early days of the treatment, or it could mean the patient is still experiencing residual anxiety symptoms. But either way, this still suggests incomplete recovery or potential adverse effects to the new medication, but not effective management. All right. If you selected, I'm sleeping better most nights, but I still wake up occasionally feeling anxious, this is incorrect because, of course, this only shows partial improvement. The patient still has episodes of nocturnal anxiety, which implies the treatment plan is not fully controlling the symptoms yet. And remember that sleep improvement is a secondary benefit. It's not a primary treatment outcome. Now, if you selected, I've been able to handle work meetings without feeling overwhelmed, this is not the best indicator. Functioning at work is a great functional outcome, but it's not as direct as a measure of panic disorder improvement, such as when they're saying no panic attacks or less anxiety. And the absence of feeling overwhelmed is very subjective, and this one does not confirm whether the patient has any physical symptoms of panic. Now, here, you need to prioritize those primary outcomes wherein we need to see reduction in their panic attacks, reduction in their anxiety, and make sure that you evaluate the subjective and objective data together and make sure that you know which outcomes are specific versus general outcomes and primary versus secondary. And you got to make sure that you're staying within the nurse's scope of practice. So remember about teaching, monitoring, and coordinating care. So this time, let's do a recap of what we just learned from this case scenario. So for that test item number 1, that was a hotspot that allowed you to recognize the cues. So here you identified the clinical findings specific to a panic attack diagnosis. In test item number 2, that was a bow tie test question. So in there, you generated those solutions by prioritizing sedation as the key adverse effect of alprazolam and selected those appropriate teaching points. Now, for test item number 3, that was a matrix multiple response, and you were allowed to analyze those cues and selected those RN appropriate interventions that are also tailored to manage acute panic symptoms for chronic stress and preventing recurrence. For test item number 4, that was a drop-down rational. You were given a chance to generate those solutions. And in there, you differentiated panic disorder from other conditions with overlapping symptoms. And for test item number 5, that was a multiple response grouping. You were able to prioritize hypothesis. And here, you anticipated a medication transition for long-term panic disorder management. So that was more of the discontinuation of the alprazolam into starting the sertraline. Number 6 test item, this was a trend. You were given the chance to evaluate the outcomes of the patient care. And so there you evaluated the effectiveness of a multifaceted treatment plan for panic disorder using a longitudinal data and patient statements. So if you had learned many things from this discussion, don't forget to like and subscribe this video, share it with your friends who are also reviewing for the NCLEX RN. Don't forget to push all the buttons. Push that thumbs up, and also if you have not subscribed to the channel yet, go ahead and do that. I'll see you in our next review session. Thanks for watching.